Okay, welcome to the deep dive.
Glad to be here.
Today, we're tackling myotonic dystrophy. We've got some solid revision notes in front of us.
Yep, looks like a good overview.
And the plan is to really boil this down for you get to the high-yield stuff you need for revision, focusing just on this condition.
Making it stick. That's the aim.
Exactly. Hopefully in a way that's, easy to digest. Okay, let's unpack this. Where do we start? Maybe the definition.
Sounds good. So, what is myotonic dystrophy, fundamentally? According to these notes, anyway.
Right. Well, the notes kick off defining it as a genetic disorder, and it highlights two main things.
Okay.
Progressive muscle weakness
Uh-huh.
and this thing called myotonia.
Myotonia. Yeah, that's a key term. The notes explain it as delayed muscle relaxation after you contract a muscle, right?
Yeah, exactly. Like if you grip something really tight, your hand sort of stays gripped for a bit longer than it should. That kind of feeling.
That's a good way to think about it. And importantly, the source stresses it's not just muscle weakness.
No, it's labeled a multisystem disorder. That means it hits other parts of the body too, various organs and systems.
That multisystem aspect is crucial. And it mentions the two types, DM1 and DM2.
It does. It says DM1 is more common and, well, often more severe.
Right. And it's an inherited myopathy, a muscle disease passed down. Typical onset, the notes say, is around 20 to 30 years old.
Affecting skeletal muscle, obviously, but also cardiac heart muscle and smooth muscle too, like in the gut.
Yeah, so that multi-system thing comes up right away, even in the basic definition.
Okay, so that's the what. Now, maybe the more complex part, the why, the genetics. This is where it gets really interesting, I think.
Definitely. It's all down to mutations, but a very specific kind of mutation. What's fascinating here is the mechanism.
The notes call it a trinucleotide repeat disorder. That sounds technical.
It just means certain short sequences of DNA letters get repeated over and over again, way more times than they should.
And the notes break it down for DM1 and DM2.
Yep. For DM1, it specifies an expansion of CTG repeats, that's cytosine thymine guanine. And this happens in the DMPK gene.
DMPK gene on chromosome 19, it says here.
Exactly. CTG repeats, DMTK gene, chromosome 19, that's DM1.
Okay, CTG, DMPK 19. Got it. And DM2.
For DM2, it's a CCTG repeat, so 4 letters this time. And it's in a different gene, the ZNF9 gene, which is on chromosome 3.
CCTG, ZNF9, chromosome 3. Okay. Different repeat, different gene, different chromosome. How do these extra repeats actually cause the problems, the symptoms? The notes mention abnormal RNA processing.
That's the key. So when the gene with all those extra repeats gets transcribed into RNA, which is like the messenger molecule, that RNA molecule itself is abnormal because of the repeats.
Yeah.
This faulty RNA then kind of accumulates in the cell nucleus, and it messes things up. It interferes with the processing of other RNA molecules from other genes. It gums up the cellular machinery.
Wow, so it's not just the one gene that's affected in the end. The abnormal RNA causes wider problems.
Precisely. It disrupts how lots of different proteins are made correctly, affecting various cellular functions. And that's why you see problems in so many different tissues: muscle, heart, eyes, brain, you name it. It's a downstream effect.
And the notes link the number of repeats to how bad it is.
Generally, yes. More repeats often means it starts earlier and the symptoms are more severe. Though it's not always a perfect correlation, it's a strong trend.
Okay, so just to recap the core genetics for revision.
Yeah.
DM1 is CTG and DMPK on 19. DM2 is CCTG and ZNF9 on 3. And it's autosomal dominant inheritance.
Correct. Autosomal dominant, meaning you only need one copy of the faulty gene from one parent to inherit the condition. So a 50% risk for each child if one parent is affected.
Right. And speaking of risk, having an affected parent is the main risk factor listed.
Yeah.
And the notes also describe how it can get worse in later generations.
Yes, that's the phenomenon called anticipation, although the word isn't used here. The unstable repeats can actually expand further when passed down.
So a child might have more repeats and potentially earlier onset or more severe symptoms than their parent did.
Exactly. That's a really important feature of these repeat expansion disorders. It's quite striking.
Okay. We have the what and the why. How does it actually look? What are the clinical features you'd see, according to these notes?
Well, there's a pretty long list, which, again, highlights that multisystem nature. Common things include the progressive muscle weakness we mentioned, the myotonia, definitely muscle wasting.
And then things outside the muscles, like cataracts.
Yes, cataracts are very common. Cardiac abnormalities, problems with the heart, endocrine issues like hormone imbalances, cognitive impairment, even gastrointestinal problems.
That's quite a spread. The notes also mention some specific general features. Myotonic facies,
Right.
long sort of haggard look.
Yes, that distinctive facial appearance. Also, frontal balding, especially in men, bilateral ptosis, that's droopy eyelids on both sides, and dysarthria, which is difficulty speaking clearly.
Those facial signs that trophytosis, the overall look, can be quite characteristic, can't they?
Yeah,
Might make you suspect it.
they can be big clues. And then there are other features listed too. Weakness in the arms and legs, often starting distally, so hands and feet first, which fits the DM1 pattern.
Right. Mild mental impairment, diabetes, testicular atrophy in males, various heart issues like heart block or cardiomyopathy, and dysphagia, trouble swallowing.
If we connect this to the bigger picture, you can see how the underlying genetic issue translates into dysfunction across so many systems. It's really widespread.
Yeah, absolutely. Maybe for revision, thinking about it system by system could help. Muscle, face, head, eyes, heart, GI, endocrine, cognitive.
That's a great strategy. Grouping them makes it less overwhelming, and the notes do rightly point out there's massive variability between people when it starts, how fast it progresses, how severe it gets.
So given all these potential symptoms that could overlap with other conditions, how do doctors actually pin down the diagnosis? What about differentials?
Well, the notes mention you need to rule out other muscular dystrophies, other myopathies, various neuromuscular disorders. But the key thing, the decider, really comes down to the investigations.
And the main investigation listed is genetic testing.
Exactly. Since it's a known genetic cause with specific mutations, testing the DNA for those CTG or CCTG repeat expansions is the definitive way to diagnose it.
Makes sense. Find this specific genetic fault. What else do they list?
They also mention electromyography, EMG. That tests the electrical activity in muscles.
What does that show?
It can show characteristic patterns, including signs of myotonia, the delayed relaxation. It helps confirm the muscle dysfunction.
Okay. And what else?
Echocardiogram and ultrasound of the heart, vital for checking those cardiac abnormalities we talked about.
Right, because heart problems are a major concern.
Absolutely. And then general imaging studies might be used to look at other affected organs if needed, but the genetic test is the primary diagnostic tool. The others provide supporting evidence and assess the extent of involvement.
Okay, diagnosis sort. Let's zoom out a bit. Epidemiology. How common is it? The notes give UK figures.
Yeah. Prevalence estimates range from about 1 in 8,000 to 1 in 20,000 people. And again, confirms DM1 is more common than DM2. Affects males and females, with all that variability we mentioned.
So not super rare, something you might actually encounter in practice.
Definitely worth knowing about.
And then management. Big section here. The notes are very clear.
Yeah.
There's no cure mentioned. It's all about managing symptoms.
Supportive care is the phrase used. Since you can't fix the underlying genetic issue, you focus on managing the problems it causes, system by system.
So what specific strategies are listed? Let's see. Physical therapy.
Yeah, PT to help maintain muscle function, strength, mobility as much as possible.
Assistive devices like braces or walkers, presumably.
Things to aid mobility and independence when weakness progresses.
Speech therapy. That's for the dysarthria and dysphagia.
Correct, helping with speech clarity and swallowing difficulties, which can be significant problems.
Cardiac monitoring makes sense given the heart risks. Regular screenings.
Yep, checking for things like cataracts, diabetes, thyroid problems, those other systemic issues, catching them early.
And the last point is crucial. Multidisciplinary care.
Absolutely essential. Because it affects so many body systems, you really need a team of specialists involved: neurologists, cardiologists, pulmonologists, endocrinologists, ophthalmologists, therapists. The list goes on. Coordinated care is key.
Okay. And what about the outlook? Prognosis.
As you'd expect, it's variable. Depends on the type, the number of repeats, the severity. It is progressive. It tends to worsen over time. And sadly, there's no cure.
The notes mention reduced life expectancy in severe cases.
Yes, particularly due to respiratory problems, weakening of breathing muscles, and those cardiac complications. They are the major risks impacting lifespan.
But it does add that good management can help people maintain a decent quality of life for a long time.
That's the crucial takeaway on prognosis. While it's serious and progressive, proactive, supportive, multidisciplinary management makes a huge difference to quality of life and can mitigate some risks.
Right. And tied into that are the complications. What specific ones are listed?
It details them. Respiratory problems, the cardiac abnormalities, arrhythmias, cardiomyopathy, cataracts, endocrine issues, diabetes, thyroid, GI dysmotility, problems with gut movement, cognitive impairment, and also emotional difficulties, which are understandable given the condition's impact.
So regular monitoring is stressed to catch these things early.
Mhm.
Again, linking back to that multidisciplinary care approach.
Exactly. This raises an important question, really, about managing such a complex, progressive condition. It's about balancing the treatment of symptoms with maintaining overall quality of life.
That proactive monitoring is key for optimizing outcomes.
Hmm.
Okay, thinking about all of this, the genetics, the huge variability, the progressive nature, but also the potential for management to help. Here's a final thought, perhaps, for you, the listener, to mull over. Given how widely the symptoms and the speed of progression can vary from person to person with myotonic dystrophy, how might a clinician best approach that initial conversation with a newly diagnosed patient about their future? How do you communicate the seriousness and the progressive nature while also instilling hope and emphasizing the positive role that management and support can play in their quality of life?
That's a tough balancing act. It really gets to the heart of patient communication in chronic illness, a very important point to consider.
Indeed. Okay, that brings us to the end of this deep dive into myotonic dystrophy based on these revision notes.
We hope breaking it down like this has been helpful for your understanding and revision.
Yeah, hopefully useful. Thanks for joining us. And if you are revising for the MSRA, don't forget to check out pastthemsra.com.
And there's also freemsfree.com for, well, free resources.
Definitely worth a look. Okay, until next time.
Keep well and keep learning.